Today, we have a special seminar, a special guest that I'd like to introduce. And before we hand it over to her, and those of you know the title, but she'll be going through her presentation and title. But first, I wanted to tell you about Dr. Nambiar. Dr. Nambiar is the program head for health systems and equity and the regional coordinator for the Healthier Societies strategy at the George Institute for Global Health in India. She holds appointments at the Manipal Academy of Higher Education in India, the University of New South Wales in Australia, and Harvard T.H. Chan School of Public Health. Her experience over 2 decades includes conducting research across 12 Indian states that you'll hear about, and 6 low and middle income countries, providing technical assistance and postgraduate teaching in health policy, systems research, and health systems policy development, with an emphasis on social exclusion, health equity, and health for all. Dr. Nambiar has supported training workshops and capacity building related to health inequality monitoring in 4 WHO regions. She's also a former Fulbright, Fogarty, and NIH scholar, currently has an intermediate fellowship in public health from the Wellcome Trust Department of Biotechnology, India Alliance. She received her doctorate in public health from the Johns Hopkins Bloomberg School of Public Health. So I know it's a long introduction, but it's hard to not have a long introduction for Devaki. So Dr. Devaki Nambiar, please take it over and say hello to Rutgers faculty and friends.
Great. Thank you so much, Rick. Good morning, everybody at Rutgers, or good day to everybody from the Rutgers Global Health Institute. It's an absolute honor and delight to be speaking to you today. I've had wonderful interactions with your faculty so far and look forward to many more. I'm going to share my screen so I can get some of these slides over to you. I hope this is visible.
Yeah.
Yeah, okay. I'm going to make this full screen now. And so I think that sort of overly long bio takes you through the kinds of experiences and interests that I have. And I think the foundational one is on equity. And I've had the good fortune of working in a number of low and middle income country contexts, but being based out of India for a good decade now. And almost 2 decades of research and practice work in these contexts. I'll be focusing in large part on my experiences and work in India, but would be keen to answer questions and talk about some of the other experiences. I've talked about them a little bit as well. To start off with, just to put my positionality out there, I think, which is critical in equity work. I'm an intersectional feminist and began my career actually as a human rights educator in New York City. I then was lucky to receive public health and social science training, mixed methods research over at Hopkins, where I honed my interest in working in low and middle income country settings, especially in India, which is where I did both my Fulbright and my doctoral research. They were connected, following which I did a Fogarty in Tanzania and became increasingly interested in health systems with the initial lens of looking at social exclusion and a broader interest in health for all. This then, around the time that I was doing my PhD, I think connected very strongly with the work of the World Health Organization's Commission on Social Determinants of Health, where I saw articulation, at least in my career, in the clearest of terms, of the relationship between social justice and health, and hence the interest in health. And I saw myself as one of the, I wasn't directly involved with the 9 knowledge networks that the commission had, but I felt very strongly connected to the kind of work that was happening and this idea of social determinants in health. And as those of you who are very familiar with the commission's work would know, the commission had these 3 very straightforward but extremely complex recommendations. The first of which was to improve daily living conditions in service of the achievement of health equity. And then to tackle the inequitable distribution of power, money, and resources, really looking at the upstream determinants or the structural determinants of health inequity, and also to measure, understand the problem, and assess the impact of action. And as a health equity researcher, this is where I really saw my space and the possibility really of my contribution. And some of our initial thinking and work on this is in an edited volume, which looks at the social determinants of health in India. And by actually a sort of coincidence, one of the commissioners on the CSDH is a mentor of mine since I was age 17. So I've really benefited, I think, from great mentorship throughout my career, which has brought me to the point of sort of coming to a conclusion about what health equity research can do or what it ought to do. And so I started this list, which I use in my teaching and as a sort of talisman for my research as well. And I'm happy to present the different experiences and findings of my research work in line with some of these ideas on the role of health equity research. So the first of these is the work of conceptualization, historicization, and theorization of inequalities as distinct from inequity. Inequity being a normative concept and inequalities being more of a descriptive concept. Of course, there's some debate about this as well, but we can get into that. The other aspect beyond historicizing and conceptualizing is looking at magnitudes and the nature of inequalities. Here's where things like intersectionality come in, inequalities within inequalities, interaction effects between inequalities, and so on. And then connecting that idea to inequity, which is unfair, unjust, and avoidable inequalities, trying to identify what the determinants of that are and what the pathways to inequity look like is another, I think, role for health equity research. And this, to some extent, can help inform entry points to address inequities. But as one of my mentors in India has told me, it is usually not enough to understand just the problem to identify entry points for the solution. That quite often the solution space is a separate endeavor. And I've tried to marshal some of my research abilities in that space as well. And some of that, of course, involves looking at what equity-based interventions already exist and assessing their impact. And that's been another area of my interest and focus. I think one of the critical areas of work of health equity research, which I think is implicit in a lot of the work that's done more generally, but is more strongly articulated in health equity research specifically, is giving voice to populations who are typically not heard or are underserved by the existing health systems and the societal formations in which we operate. And this sometimes, not always, but sometimes requires some flexibility in the ways that we understand and deal with knowledge. And so in some cases, it requires convening across perspectives using more than some of our positivist, frequentist approaches to looking at global phenomena, including in the health sector, and using epistemologies that sort of push the boundaries a little bit. And I think in the context of decolonization, that has also become increasingly important for me as someone who operates out of the Global South. And I think COVID has really brought a lot of the importance of these areas of inquiry into sharp focus. This is an article by some of my colleagues who really are sort of leaders in the health policy and systems research field. And there's a strong contribution that health policy and systems research can make to socially just health systems. And this article really points out a number of, I was happy to see that it concurs with my sort of approach to health equity research, but importantly adds another, which has to do do with how decision-making functions. And this applies actually not just to sort of global governance decision-making in, say, for example, national health policy making, but also at the level of what we call street-level bureaucrats. So a frontline health worker making decisions about who she's going to talk to and about what, and how she's going to structure her day and her tasks and her accountabilities to the community that she works with. So there are these decisions across the board, and understanding the relationship of these decisions to equitable health and other outcomes for populations is what I've been interested in. And so what I'm going to do now is present to you some examples of my application of these ideas. The first of which is some work that we've done, now about 6-7 years ago in Indonesia, where following some workshops where we presented some tools to monitor health inequalities under the aegis of the World Health Organization. There's a division specifically working on monitoring health inequalities. The national government became particularly interested in identifying which inequalities to focus on in the country. This really pertains to the issue areas that I was mentioning, which have to do with magnitudes and the nature of inequalities, and really assessing the impact of equity-based interventions, because the national government had in fact introduced a number of different interventions after the sort of economic crash in the late 90s, and really trying to contend with some of the inequalities in the country. And so they really sort of embraced the opportunity to work with the World Health Organization. And I was there as a facilitator for this process of training, technical meetings, preparing data across the entirety of Indonesia's health sector. So all the different kinds of surveys, the health information systems they have across issue areas, existing work, academic and programmatic in health reform, to look at this issue of health inequality. So we first mapped all these data sources and then looked at how granular the data was. And then we prepared the data to carry out analyses that I'll show you just now. And it was an extremely extensive, but very, I think, rewarding process for us as well as for the national government. And not only did that happen, and we launched what you see at the bottom right of your screen, the state of health inequality for the whole country, but they said, well, we should publish this. And we said, well, you have. And they said, no, we should have peer-reviewed journal publications. And so we produced a special issue of Global Health Action. So the other article you see there is an example of, is one of the articles from that work. But what I thought would be interesting is to show that, you know, when we create these opportunity structures for national governments to explore and understand their health inequalities, a lot of the existing innovations in those countries have an opportunity to come out. And so an illustration of this is analysis of the Public Health Development Index, an indigenous index developed by the government of Indonesia some years back, that they then decided to use to look specifically at the issue of inequalities. And so we helped them with the mapping process, where they identified a couple of their surveys, and from those surveys evolved a Public Health Development Index using 30 indicators with 7 sub-indices ranging from looking at non-communicable diseases to environmental health, to reproductive, maternal, child and neonatal health, and so on, and creating index scores. And these were computed for each province in the country, across the different regions, across the islands of the country. And it wasn't just a question of finding out the score in these index and its indices, but looking at inequality in the scores within the different provinces. So really adding a level of granularity to see, where were populations being left behind. And I think what was another interesting part of this whole collaboration was that the Indonesian government helped us with the development of a bespoke piece of open source software called the Health Equity Assessment Toolkit, which actually already exists and uses DHS data on the WHO website. But they helped us evolve this into a customizable piece of software to analyze health inequalities, where you can just upload your own data set and look at summary measures of inequality. And so what we did, for example, here is that we use this thing called the weighted index of disparity. And we were able to compare all the different islands across Indonesia and individual provinces within those islands. And on the one hand, you'll see on the x-axis what the average of the Public Health Development Index the overall score is. So the further to the right you are, the higher your overall province average is. And the lower you are, the lower your level of disparity or inequality. And so the bottom right quadrant being the best quadrant to be in, as you can imagine, the sort of more urbanized and more advanced areas of Indonesia, like Jakarta and so on, are in the bottom right, where you see provinces like Papua and East Nusa Tenggara on the top left, where there are inequalities within those provinces as well. So not only are they laggardly in terms of averages, but also have an experience of high inequality. And I think this realization that, you have the issue of particular populations being left behind was an important one for the Indonesians to sort of contend with and look at. And also the fact that, your own indices can be used to look at inequalities, your own data can be used on this open source software was another realization. So drawing on these lessons, I sought to try to do this at the subnational level in India. In the southern Indian state of Kerala, where I had been working for a number of years and now have a 5-year project that's ending this year, where we entered into a close collaboration with the Kerala government. And here again, we were seeking to do what we were trying to do in Indonesia, understand the magnitudes and nature of inequalities, but also look at determinants of and pathways to inequity. And also in working closely with government decision makers, understand how decision-making itself functions. So the first thing that happened is when I went to the top bureaucrat in the health department, I said, we want to select these indicators. We're interested in universal health coverage and health reform. You've just had a reform process. Let's use some surveys and find this out. And he said, no, I want you to consult with people all the way down to the facility level in my district. And I want them to help you define what you're going to be looking at. So we undertook this process. And of course, there's a research method for that. It's called, there's nominal group technique methods, and this one's called the Delphi method. And what we did is we went through multiple rounds of ranking, and from a long list of UHC indicators, of course, there's the 16 global indicators that the WHO uses. But if you look at all the different compendia of indicators related to health for all and universal health coverage, you'll come up with 800, or that's what we did. And then we reduced those down to about 38 of them, and then went through a ranking process and arrived at 23 of them that the state of Kerala really cared about. And then we sought to sort of pull out the data on these indicators and try to look at the question of inequalities. And once we did this, we found that a lot of the indicators that even the government officials themselves had selected had some problems with them, right? So we found that in many cases, data were available at the facility level, but they were in registers, and I think in many countries, this is the case, that you have all these different bits of data, but they're in like 7, 8, 15, and in the case of India, 43 different registers at the primary healthcare facility level. And only some of these pieces of data in only some forms is going up in any direction. So a lot of wasted time. I mean, if you're interested in health equity, you're also interested in sort of not imposing on people's time. So one of our big findings here was that, there's all this data, but the ability to use it was really sort of hampered in many cases. A lot of the global indicators we found just really didn't have resonance or meaning at the local level, so much so that expecting people to look at inequalities in them was kind of meaningless. So the operationalization of some of these really needed to be thought through more carefully. In some cases, thresholds for interpretation didn't make sense. So for example, you would have, proportion of those screened for hypertension who are hypertensive, the proportion of those on medication, right? So at the face of this, it seems like a good indicator. But when we went down to the field level, they said, well, look, in many cases, we don't want people to be on medication. We want them to do lifestyle changes. So we're getting dinged for people doing the right thing. And people are identifying these inequalities where there actually isn't. I mean, we don't think there's a problem. So don't you need to change your indicator? So, I mean, that's a very good point, isn't it? So we should be thinking about crafting our indicators more carefully across the board. And really, it's this sort of triangulation and these insights from the local level that become important. And once you do that, you usually end up needing to gather primary data, which is what we had to do. And in this case, looking at the odds of reporting any kind of insurance, we did find some inequalities. This was a primary data collection exercise carried out in 4 districts across the state of Kerala. We had data for about 13,000 individuals. We found a couple of interesting things. We found that by design in some cases and because of implementation in other cases, groups were being left behind. So you could see that folks who were never married as compared to folks who were, religious minorities as compared to the Hindu majority, as well as what we call the scheduled tribes groups, so First Nations groups who are identified in what's called the scheduled tribes category in India, as compared to those in the general population, had significantly lower odds of insurance coverage. In some cases, this is by design. So health insurance across India is sort of designed to cover families. It's not actually designed to cover individuals. And so if you're never married, you sort of get left behind. In other cases, though, this is certainly by perhaps due to implementation, which I would argue is actually a design failure, where you have tribal populations who are routinely excluded from even health service access, not having insurance coverage either. And then you also see some other issues with wealth inequalities, where relative to people from the wealthiest quintile, you'll see quintile 2 and quintile 3 populations, so poorer populations, having higher odds of insurance, which is good, which is by design. We want poorer populations to have higher insurance cover, but you don't see that for quintile 1. So even though they on average had greater odds of insurance cover, it wasn't significantly higher than the 5th quintile, which is a real problem when health catastrophe or a catastrophic expenditure, when a health catastrophe turns into catastrophic expenditure, which is what we started to see once we started looking at the expenditure data. So we knew that there's this data on populations getting left behind. And when we interviewed health system actors about who they thought was getting left behind, we carried out these interviews across those 4 districts. We got an interesting response. Of course, there are vulnerable populations in Kerala. These medical officers, frontline health workers, community leaders, that's what they said to us. And they said, well, there's schemes for these populations. And in a sense, almost defining these populations by the fact that schemes existed for them, right? So saying that, yes, there are tribal populations that are left behind. We have schemes for them. Kerala has one of the world's most well-known palliative care programs. So palliative care patients, the elderly are other groups that are vulnerable. They are being left behind. Persons with mental illness, migrants, fisherfolk, persons affected by endosulfans insecticide exposure. These are all groups that are being left behind. But interestingly, these are all groups that are not per se getting left behind because they have schemes that exist for them. And so you see at the bottom, even when we asked about the COVID context, the priority given to these populations is what is underscored, right? So first we vaccinated these vulnerable populations, and then others were vaccinated. Or, for example, these populations, and we know a medical officer in a southern district said, these tribal populations, palliative care patients, and so on, were the ones who were more affected. So that awareness is there, but in a sense, it's shaped very much by the existing design of the health system, rather than a particular sensibility to identify who's left behind. At least that was our sense from these data. We're actually speaking to populations in these left behind categories to understand their experience of the health system, to see how that triangulates with what other health system actors are saying. But coming to this tribal frontline health worker program, Kerala does indeed have a lot of these programs for underserved populations, including Indigenous First Nations populations. And we thought it might be useful to understand this newer one-of-a-kind program that exists in the state, to see how it's faring. Is it sort of as an equity-based intervention? What kind of impact is it having? And so there was a lot of gatekeeping for this work. We had to seek a lot of permissions from the tribal welfare, the forestry department, because a number of these populations live inside forested areas that are, in a sense, they're protected or reserved areas. And we undertook qualitative case study research with the Katunayakan Nation, which is a specific nation among the many that are there. There's something like 60 or 70 different tribal nations across Kerala. So we carried out this research, and of course, COVID struck, and I mean, there's a whole separate paper you can see here about using telephones to carry out interviews with unreached populations where you have a lot of issues of access. And that in itself was an interesting process when you're looking at determinants and pathways to inequity. But in terms of our findings, we found that the institution of this frontline health worker program in Kerala, which comprised people from the community serving as frontline health workers, was in many ways well received because those frontline health workers, or ASHAs as they're called, were speaking the local dialect. So the fundamental bit about trust and communication in the health system by way of the local dialect being spoken was seen as an enabler or as a positive feature of the program. For health workers themselves, the amount of self-confidence and ability to communicate that was facilitated by the program was appreciated. And indeed, in many of these areas where the program is running, it's called the Uramitram program, existing programs and community networks have sort of set a strong base for even this health focus to operate well. So this includes things like community kitchens and the activity that's generated around that being a good platform for health to sort of come in and be another issue, particularly in light of COVID. But challenges remain, as you would have seen in equity work across the world, particularly in LMIC contexts, and actually even outside of LMIC contexts, where you have large distances and remoteness. It's really hard for frontline health workers, as it is for communities, to reach health facilities. It is that it's difficult for community health workers to reach some of those areas. Some of those are conflict affected, or they're called Nakshal areas in India. And of course, these are forested areas where you're sharing your ecosystem with animals. And all of the costs of traveling and commuting back and forth are borne by ASHAs themselves, by the frontline health workers themselves. And the irony is that India operates with population-based norms for compensating the work that ASHAs do. So the incentives they get are based on X number of families, but these are small pockets of tribal populations with not that many families. And so not only are you having to spend extra money to get to them out of pocket, you're also given less by way of incentives because the population is so small. So this was a source of sort of disenchantment for a lot of the tribal health workers. And they also felt discouraged because they were not able to support important areas of work. So challenges that the community faced had to do with alcohol use, violence, financial insecurity, to even buy medicines, things like that. And also challenges faced by men. And by design, a lot of these programs are really focused on reproductive, maternal, and neonatal care, even as the range of issues that affect populations, not just in this state, but across India, have really, there's been an epidemiological transition. So we explored that to some extent in northern India, actually, as well, this idea of the maternal child health to NCD transition, and what are the inequalities that we should be concerned about there. I happen to serve on a national task force that looks at this, and we were interested in inequalities, of course, in this space, but also entry points to address the inequities as this larger policy shift is happening in India to not just provide maternal, neonatal, and child-related care, but also NCD care. And so in these northern Indian states, we tried out this methodology called lot quality assurance sampling, which is something that frontline health workers can actually themselves use just by designating supervision areas and using a random sampling methodology, identify only 19 people in their group. And depending on a threshold that they have, if say, for example, your threshold is 65%, out of my 19 people, if 11 people have not met the threshold, say, of screening, that means that representatively for the whole population, I have not met my target. I don't know exactly what the coverage is, but I do know that I haven't met my target. But if 12 of those people say that they have been screened, then I know that I have met my target. So it's much easier for me as a frontline health worker to speak to 19 people instead of serving 2,000 to have an idea of how I'm doing. So we tried this methodology. And it's been used actually in India and elsewhere, including in conflict settings, to look at coverage of different kinds of healthcare services. And this was one of the first times this was done with NCD care. And you see a couple of interesting trends. This is something that I reported for Kerala as well. You see here in supervision areas 3, 4, and 5 in central Delhi that and the white squares mean that the white cells mean that the coverage wasn't achieved. And so you actually see men being left behind here with respect to NCD care. So on the one hand, you can identify that, across areas in this district, men are being left behind, but you can also see situations where both men and women are being reached. So in the supervision area 2, this is below poverty line people and above poverty line people, all seem to be reached. And this is all in the catchment area of one primary health center. So what we undertook to do then is have a discussion with the medical officer there and say, look, there's something going right in this sub area of your larger catchment area. And then in these others, there seem to be men being left behind. And, as those of us who do knowledge translation know, when you say all this to a medical officer, they're like, I know that, right? But we said, look, now you have scientific evidence that's suggesting this, and we need to do something about this kind of gap filling. So, and it's easier to sort of explain some of these concepts. And we had a good experience of trying to, in the early days of the NCD program, getting this across to our colleagues in Delhi and in Uttar Pradesh. Another population that I've been working on, again, to look at entry points to address inequities, but also with more of a focus on unheard and underserved populations, is the urban poor. And I've been had the good fortune of being involved with the India's National Urban Health Mission. In 2013, gosh, that was a while ago, we went through a process of visiting 31 different cities across the country and speaking to 40 different types of groups of urban poor. So people in sex work, people in construction work, folks who live on the street, so they're called pavement dwellers in India, elderly women who may be in some cases abandoned or living in shelters and so on. So these types of different groups. And what was really great is that we drew from them the information that they felt should inform their health systems, and we came up with recommendations for the Urban Health Mission. And 5 years after that, we sought to revisit some of the challenges we had identified in that stock-taking exercise. And some of the problems we noticed for the urban poor in that exercise in 2013 were that the urban poor were invisible and ineligible in the system because they lacked various forms of IDs. We found that they had latent care needs that were not addressed at all, that even they didn't want to address, and the issues that they had couldn't be followed up for want of money or for want of continua of care in the health system. There were high and hidden costs. So you'd go to get free care in the public health sector, but be told to get this whole list of tests and come back and do all of these things. And so those would be hidden costs. Location, distance, and accessibility, ironically, would also be challenges, even though, health facilities are chock-a-block in urban areas, but the actual physical access to them could be really fraught because it wouldn't be the right place for the type of condition you had, or you would still need to go and get a test done somewhere else. So the appropriate services were not accessible. And of course, there was the challenge of disrespectful behavior on the part of health providers, and even those facilitating access to services. And so when we sort of revisited this through ethnographic fieldwork over a 2-year period in 2 sites of Delhi, we focused on the homeless in this instance. And we could see that some of these challenges just really nothing had changed in about the 6-7 years since we had made those initial recommendations. And you can see a situation here, for example, where someone had such a high set of costs that that they just left. There was nothing they could do about trying to keep fighting to access care. But I think there were more fundamental challenges of access and even of exposure that homeless populations in Delhi face. Very dire situations of exposure to heat, to vermin. You can see here on the bottom left, there's a bottle that's been chewed up. That's a saline solution that's been chewed up by a rat. You can see heat exposure that for which it's very hard to get treatment or care for this mother. Addiction and other comorbidities also hamper health seeking, but also this means that some of the remedies or medication that they receive are not as successful at addressing their health issues. And it's very hard to have adherence and things like that. Insecurity and violence are rife for a lot of these populations. And there really is a precarious situation in which they're living, where it isn't really health that is a concern, but death that is more of a challenge. So that's been a very humbling piece of work that we've been doing, and we're trying to move ahead with trying to have a homeless policy and really bring in reform, working with civil society partners. And really, civil society has been a beacon of health reform in India as in other parts of the world, and actually conceptualizing and historicizing that and kind of seeing that in light of how decision-making functions is another area of our work that I've been interested in doing. And we wanted to do this in a way that isn't a case study, that isn't just qualitative or survey research, but that really privileges the voices of people who have actually been transforming health systems. And so we came up with this methodology of the witness seminar, which actually is an oral history of a phenomenon, told from the perspective of those who have witnessed and participated in the creation of that phenomenon. And here we've partnered with the UHC 2030 civil society engagement mechanism, and we've carried out a number of witness seminars in India, 5 of them actually, drawing from the Social Participation for Health handbook that the WHO put out last year. And we've been interested in how community action for health in one of India's flagship health programs came about. And we have some great insights on that. We're hoping to do more of these kinds of witness seminars in a number of countries across the world in partnership with the civil society engagement mechanism. And you can see some of these findings in terms of making that transformation and change, that you really do need sort of boundary spanners. So decision makers who also have a sort of civil society orientation and create those spaces for civil society to influence national policy. At the same time, once those policies are in place, in many cases, you will have hyper-centralization, and civil society is left to press on with actually making transformative change in spite of some of these programs, because of some of these programs. And larger reforms having to do with devolution, subsidiarity, and decentralization in many cases have helped make transformative change, which is certainly the case in Kerala, the state that I was talking about earlier, where this thing called the People's Plan campaign has been put in place. So we've created these transcripts from witness seminars and are looking forward to doing this kind of work in other parts of the world as well. So I think I might have gone a little longer than I intended, but this has been a sort of snapshot, if you will, of the kinds of work that that we've been trying to do here at the George in collaboration with a number of institutions. And going forward, we're very interested in strengthening local, but also regional and global collaboration related to health for all and sort of reducing social exclusion and leaving no one behind on the path to UHC. And this involves, to some extent, piloting methods and methodologies like the witness seminar, lot quality assurance sampling, some of these others that help give voice and enable co-production and really bring decision-making sort of closer to local areas and to local decision makers across the health system and more. And we feel that this, in turn, can allow engagement and policy transformation in ways that allow knowledge to be visualized, allow it to be accessible and relevant, for instance, in the Heat Plus software, which allows data visualization and stuff like that. And so for people to really start to see the problems, we feel that can really help them to start seeing what needs to transform. So this has really been a snapshot of the kinds of experiences that I've been involved with. I will end with just this statement from one of my mentors. I have really benefited from a lot of privilege in my life. And I think the amount of reflexivity that health equity research requires is really sort of another talisman for me, which this is actually a quote from Harsh, but I leave you all with this. And I'm happy to have your questions at this point. Thank you.
Great, Devaki. Thank you. You'll get some virtual claps and some real claps. Thank you so much. And for a really well organized, I really like how you have the 8 areas of health equity research, or how their approaches, how they would tie in then to action and impact and the plans going forward on your last slide. But let's have it, I know there's a lot of health equity researchers here and in different aspects. So let's have some comments, questions, ideas from the group for Dr. Nambiar.
If I may, I can.
Much of a ramble.
Sorry.
Please go ahead, anybody.
Neeraj,
Yes.
do you want to go first? Okay, I'll take that. So I was just wondering your perspectives on, given your experience, where do you see synergies between sort of global health equity internationally, using a US perspective? Where can the United States, or the United States issues that we confront here, where can we learn more from what goes on around the world, and vice versa? Where can perhaps we in the United States sort of lead, those of us who focus more on health equity issues in the States? Where can we perhaps step into and contribute more to global equity?
Charles, maybe you can introduce yourself, and others could, only because we have such a diverse group that all does fit into health equity. But
I'm sorry.
No. You go ahead.
Hello, Dr. Nambiar. I'm Charles Centio, and I'm based in New Brunswick. And I am an assistant professor in the School of Communication and Information, Department of Library and Information Science. And I have worked both internationally and domestically, but I haven't quite worked out how to make those sort of connections yet. I certainly have personal connections, but I'm certainly interested in your perspectives on that, given that I'm a health equity researcher who does community-based research.
All right, thank you. Thanks, Charles. Should I go one question at a time, or would a couple of people like to ask? I'm happy to take that question to start off with.
Why don't you go ahead? Yeah.
Okay. Yeah, I mean, I think this is an area or a field that sort of keeps changing, and there's definitely scope for sort of bidirectional learning. One of the areas I feel where the US has really sort of advanced thinking, but also policy making in many ways, I guess not uniformly across the country, but as it pertains to sort of looking at gender mainstreaming and rights-based approaches with respect to SOGI, so sexual orientation, gender identity, and expression. I think that, and of course, Rutgers is a leader in that, but the US and Rutgers are leaders in sort of analysis of and expanding our understanding of forms of inequality that pertain to sexual orientation, gender identity, and expression. And I have particularly seen in my interactions with colleagues doing health inequality monitoring at WHO that nuance, I mean, it's so for some of my colleagues, it's still that sex disaggregation and not really thinking about the need to be more granular in terms of your data, in terms of your areas of inquiry, and looking at those realities and those subpopulations. To some extent, a lot of this work has moved ahead because of the HIV movement and work on HIV and looking at different populations. That in many ways has been sort of global, but there's been a lot of back and forth. And I think there have been some key moments of steer and leadership from the US in the Global Fund, for instance, and in other places that have helped create those lessons, learnings, and ways of operating. I think there are many lessons from the HIV movement in a number of countries that demonstrate health systems transformation and how the health system can recognize different populations meaningfully and bring about policy change. I feel that the documentation of some of this has been more richly and rigorously done in the US. I feel like there's a lot of this kind of work happening in other countries. And for lack of funding, bandwidth, a number of reasons, this kind of documentation isn't happening. And in fact, that's what the civil society engagement mechanism is really interested in. And I feel that the US can be a key partner actually in doing this kind of work that involves a lot of patient listening and sort of telling the stories and doing the documentation of movement building and equity-based work in other countries. The civil society engagement mechanism for me is one of the ways to do that. I think another area where there have been important developments is the sheer sort of breadth and richness of data and in many ways the organization of data in the US, in various US systems. So the attention that NIH is now increasingly giving to looking at race, structural racism, looking at data that captures those things. That kind of political will, certainly in India, doesn't quite exist yet, but for it to become more normative requires the kind of pressure and a sense of the feasibility that the US is, and the political will that many agencies in the US are demonstrating right now. And I think whether it is through NIH or through scientific interaction and collaboration between researchers in for instance, Rutgers and institutions in India, we can start to make that kind of normative shift even within the research environment, so that people have a deeper sense of, there are structural inequalities in caste, for instance, in my country, right? That, we have to, on the one hand, gather data on, but on the other, we shouldn't atomize them. What's happened in India right now is that it's just become a part of a checklist, right? Of disaggregations that you do. And the sort of nuance of analysis isn't there. And I think what I've seen in publications from the US is that sort of richness of analysis that I think is only growing. And I think is really something that other countries, particularly LMICs, as they build their data systems, will need to have.
Great.
Maybe
Dr. Hudson, you had your hand up, and then Dr. Yal.
Sure. So Dr. Nambiar, I just want to thank you for your really interesting talk. And just by way of introduction, so I'm Shauna Hudson. I am a professor of family medicine community health here at the medical school in New Brunswick. I am actually a sociologist by training, and much of my work is US focused, looking at access to care issues within primary care settings for people who are going back and forth with cancer treatment. So one of my questions that I have for you is really around sort of the fit of your work within sort of a Rutgers setting. And if you could talk a little bit about, what was exciting to you about this position and how you see that sort of helping to facilitate and continue that work as you move forward. Thank you.
Sure. So I think for me, the fact that these the positions you have are so clearly articulating the sort of importance of health equity, of social justice, and have a global outlook. I think that to me has been a big draw. I think increasingly, though, taking a step back, there is a recognition that there isn't as much of a hierarchy of learning per se across the world in terms of lessons. So when you look even at primary care, I think there are, and I think Charles was sort of getting at this as well, there are lessons to be learned from even low and middle income country settings about, for instance, how to address continuity of care for the homeless, for instance. And we have, for example, this phenomenon in India of cancer refugees, people who have a cancer diagnosis or actually don't even quite have a cancer diagnosis and are just like floating from place to place trying to get a diagnosis or get a diagnosis that can be connected to forms of care that they can afford, right? So some of these things I think may relate or have some lessons in terms of both how they are experienced by communities, but also how they are approached by the public and the private health sector that warrant further inquiry or at least some sort of exploration. That's one of the things that I think that sort of bidirectional learning is something that I think more broadly in global health we need. But at Rutgers, my feeling was that because the Institute is in a process of sort of advancing its strategy, I think there are entry points to sort of forge additional regional connections. So I work in a number of countries in Asia, and I feel like perhaps there is interest in expanding some of those relationships and collaborations with a focus on health equity. So I serve on the board of Health Systems Global, and I'm sort of the regional representative. And I think there is a strong interest in being part of international consortia and collaboratives working particularly on non-communicable diseases, including on cancer. So I also advise the Lancet Commission on women and cancer. And I think one of the big things that had come up in one of our earlier meetings was just the lack of sort of co-learning across institutions and across initiatives. And, this exists in other domains. We just, I think, need to sharpen our process to do this even for other domain areas. So for instance, cancer and so on. And I see some opportunities for funding in this area as well, internationally and including domestically in the US. And I think given that Rutgers is looking at its strategy right now, taking advantage of some of these opportunities is something that could be looked at. I think another thing has been just that everybody I've met at Rutgers is really nice. So I've met alum at Rutgers over at WHO and so on. And everybody, my cousin went there. I mean, I've had a very pleasant sort of interaction with folks at your institution. So that's a big draw. I mean, it's as simple as that, really.
Great,
Yeah.
I appreciate it. Thank you so much.
Near?
You don't know Shauna. She's so no. Nice. My background is I direct a center called the Center for Population Level Bioethics, which does a kind of philosophy of equity in health and things like that. And I'm going to be a little unfair and kind of ask you a little bit of a theoretical question about your concept of equity and inequity, or equality or inequality. So suppose you didn't state for us what is, say, when you have an x-axis for more and y-axis for more equal. How do you assess what counts as more equal? So it's a question about kind of this area. Suppose you arrive at a situation in which everybody has a huge gap in their healthcare or the health outcomes. Would that count as an equality because they're all equally badly off, or would that count as an inequality, say, compared to other areas, or just as an inequity without inequality because it's not the way it should be? How would you, what kind of conceptualization do you put on that?
Thank you. That's a great question, and also something that we sort of teach. I don't know if you, when you teach, you use Deborah Stone's policy paradox, where she talks about all the different ways of cutting the cake and giving it out. So that's sort of at the second level, but I think let me attempt an answer that's sort of based on sort of, we're developing a course for WHO and this is how we do it there. So let's see if that's convincing for you, because if it's not, then I have some more work to do. So the idea where the entire swath of the population, for example, is deprived of some kind of outcome or some kind of coverage, we would define that as mass deprivation, right? And in that scenario, you have a kind of equality. I mean, you don't have inequality because everybody's at this low level, but you have inequity because ostensibly having this poor outcome or having this low coverage is unfair, it's avoidable, all of those things. So it's the relationship between inequality and inequity isn't one-to-one. Inequality has to do with the differences, and inequity has to do with the normative judgment around the nature of those differences, right? And what they represent. And it's actually quite common in situations of mass deprivation to not have high inequality because the whole population is underserved, right? But in those contexts, you have to find a frame of reference. What is the boundary condition of that group? Is it a group? So, for example, we use this as example in our teaching. You may consider it. It's an inequality that older people are more likely to have dementia. Okay, is that an inequity? So if we're trying to assess that statement, then we're seeing, is this unfair? Is it avoidable? Is it unjust? And many of us would argue that having dementia is unjust, it's unfair, but is it unavoidable if it's age-related? Maybe not, right? But if you're looking at a woman with dementia, in Kerala versus a woman with dementia in Ukraine right now, and who has better access to care right now, then issues of inequity will come up, right? Because their access to treatment looks different. There are things that could be done ostensibly to address that situation of that person. So I think there's there's that mass deprivation issue, but then there's what are you using as your frame of reference to determine inequity? And that's the question I think that intrigues me, that I'm interested in getting at. I hope that that answers your question at least a bit.
It's not a question, but I'll just throw in that WHO's definition of inequity is inequalities that are unfair, unjust, preventable. So actually, I'm not totally sure. Maybe the WHO would be committed inadvertently to the claim that there is no inequity here. I don't know, but I would go with your intuitions on this, because there is no inequality in the example.
Well, yeah, I mean, I have to see do they always say inequalities or do they say differences between population subgroups? So if you go further back to what inequalities themselves are defined as and define those as differences between populations, population subgroups defined by geography, and you use the differences as your anchor point, maybe then you can make a determination of inequity. I will take this up with them.
Great. Who else wants to jump in? We're at the top of the hour. We have time for one more if they're Dr. Silencio, you're being Silencio.
Thanks, Rick. I will jump in actually, just not with a question, but just to say thank you. I'm Vince Silencio from the School of Public Health, also the medical school nominally in New Brunswick, where I went to school a gazillion years ago. But since we're at the top of the hour, I won't make it a question so much as just a thank you. This has really been fascinating talk. I love the work. I love the overlap with the social vulnerability index pieces that CDC's developed in terms of the health indices. Yep. Do think that there's a tremendous depth of work that goes on across the institution that touches on all the things that you are interested in. So thank you for taking the time to chat with us.
Thank you.
Yeah, so that I don't have to say it then. Vince said it very nicely. And but if you look up the faculty and staff that are here, they're all involved in health equity, Devaki. So I think you'll see the breadth of what's going on at Rutgers. A lot of it demonstrated here by the participants. But thank you for a very enlightening hour, or a little bit less than an hour. And thank everybody for coming. Have a great week as we start to get a little bit of hint of spring coming around in our place. But thanks, Devaki, again, and we'll be in touch. And thanks everybody for coming.